Yeah, hello and welcome to Wimpole Street Dental Clinic. My name is Christian Mill, and in the following small presentation, we would like to show you one of our cases of the month here made in our clinic. So thank you very much for watching, and we hope you enjoy the video.
Yeah, hello and welcome back to a case of the month in August 2019. We have been a little bit busy the recent months in improving our laboratory in our clinic in Germany, and additionally building a clinic probably in London in the United Kingdom. So please forgive me for not publishing a case of the month the recent 3 months. This case, I hope, is going to be interesting and with a lot of insights. And as always, great thanks goes to Berit Holbel, who, our master dental technician, one of the leading technicians in our laboratory, produced this work. And of course, great thanks also to the patient enduring patiently all the pictures we've taken. A young lady, 24 years old, and you can see initially here that something is wrong with her teeth. She had a congenital missing lateral incisors, and at full smile you can see something is not right. The work has been done, made several mistakes. One of them, of course, is using a metal framework. Second mistake is to bond the central incisor and the canine together, have a 3-span bridge, but we know that it shouldn't be done like this since 1991. Then the publications from Ben Thompson and Professor Kern from Kiel and the University of Maryland, respectively. And of course, the gum situation indicates immediately that we have teeth replacement strategy here in this case. So next picture, you can even see more clearly what's wrong, especially the gum situation is not ideal. The patient came from very, very far away, had to travel 3.5 hours by train, and we needed to do many things in one visit, and the patient was also restricted financially. So we decided to place 2 one-winged Maryland bridges, each using a central incisor as an anchor. And I would have loved to do a free gingival graft here to improve the volume of the situation for the lateral incisors. But as I said, the patient was financially restricted as she was a student, so we could just do local surgery, which we did, which you'll see later on. So that's the situation again en face, and you can see here another mistake being made was the framework being extended until the incisal edge. And of course the light entering the translucent area of the incisal area of the tooth is reflected by the dark framework and is reflected gray. So that's a mistake we shouldn't do with metal frameworks and with full ceramic frameworks as well. So first what we do is, in one visit, we took the color, removed the framework, took the color again, prepared for the Maryland bridges, took a digital scan, and did the surgery to improve the gum situation. We always take pictures in the frontal view and the side view, so the technicians are not distracted by the reflections of the flash of the camera. And of course we always take a picture with the pole filter so that you can really see the hue and the value of the tooth color. Yeah, and then very carefully we removed the framework, not to damage any enamel, and managed successfully. Then placed the composite fillings on the palatal aspects of the canine, because the enamel has been hurt in that case, not by us, but the preparation of the previous dentist. And we take the color again, with and without pole filter. And if I go one step back, you can see that we have a lot of vertical height of the gum situation in the area of the lateral incisors. So that's what we used to put more buccally to increase volume. So we did exactly that, did a split flap and rolled the top aspect towards the labial aspect of the gums, and then had produced a night guard or a splint and filled that with composite and adjusted the pontic so that the teeth stay in position, that the patient has teeth in position when she goes outside publicly, and that we can reshape the gum situation. Yeah, that is the printed model from our digital scan, and then the final work. And I think it's quite beautiful. I love it, not just when the label, the visible aspect is beautiful, but also palatal aspect is very important to me, because I want to really have a work which imitates nature. So whenever you can't see that I've done something, then I've achieved a perfect result. But we're always, in this case as well, we're far away from perfection. There are always still things which we can do better. And then the label aspect, and then we go to the patient again, and we can see her here after 2 weeks, or 2 weeks after we've done the preparation, and you can see gum situation looks really nice. Volume has increased, and the papillas are there, and she brushed well, so all good to go to place the bridges. Here you can see the bridges in place, and of course the pontic can't fit. There's a gap, so we fill this gap with composite to transfer the information to the dental technician. This is the picture here, transferred to the dental technician, and that's the second try, and you can see the color of the bridge is a little bit darker, but the teeth have lost water during all the cleaning and trying on. So this is not the true color of the central incisors, but we have been a little bit too dark. So if I could do the work again, I would do it a little bit lighter. Of course, we place the bridges under rubber dam, place the gums on the first premolars, and produce ligatures with floss on the central incisors that is really perfectly prepared. I recommend that. Prepare your area before you do anything, so you really have a good bond between the teeth. Per lateral incisors, you have roughly a bonding area of 30 square millimeters. Each square millimeters carries 30 megapascal or 30 kilos, so that accumulates to around 90 kilos. So that's quite a lot. The average chewing force is something between 4 and 6 Newton, I remember. And the maximum chewing force can be from 300 to 900 Newton, but measured in the molar area. So we have ample room between the maximum chewing force and in the incisor region and our bonding strength. So now for the bonding, the enamel is just cleaned with pumice and water and then etched, and that's it. And the zirconium dioxide framework is just prepared with aluminum oxide, 50 microns, under 2 bar, that's 0.2 megapascal, and then that's it. And then bonded with panavia, and the gaps, or not the gaps, the areas of the margins of the restorations are sealed with Oxyguard 2 to allow the panavia to set. And that's the final result. And you see the color is not that bad when she's smiling. The lateral incisors are a tiny bit darker, so that's something we could have done a little bit better. And but the patient was happy with it. I was okay with it, not particularly happy, but okay with it. And so we left the work as it is. And this is the work directly after 1 week after placing in the control, in the recall session. We can see the gums look quite okay. It healed well. And here, picture taken with a pole filter, again, you can see that we could have gone a little bit lighter and a little bit more, I always call it sunny, a little bit more yellowish, than grey. So there's room for improvement for the next restoration. But overall, a good result. Patient cleans, patient is happy. And yeah, thank you very much for your kind attention. This here is the last picture of this case of the month. Actually, this is the picture I love most because you can see absolute perfect soft tissue conditions and absolutely perfect bonding to the central incisors, and it looks, with the exception of the small ridge on the incisal part, looks really, really natural. So this picture really made me happy, and the composite fillings on the canines you can't see either, so I'm happy with the result, and the patient was as well. So thank you again for your kind attention, and yeah, have a good week, and hopefully see you again for the next case of the month. Thank you. Bye bye.